Is my screen visible?
Yes, sir.
So good morning, everybody, and thank you, Santanu, for moderating this session. In fact, since this is a postgraduate lecture, not a conference presentation, so I'll be going little into the depth of the subject and I'll be elaborative as well. So my layout of the lecture for this hiatal anatomy and laparoscopic management of GERD will be on these 5 segments: anatomy of the hiatal region, preparing a patient for anti-reflux surgery, evolution of anti-reflux surgery, technique of doing anti-reflux surgery, and nuances of anti-reflux surgery. So I think I am clearly audible to everybody.
Yes, sir.
Okay,
Yes,
fine.
sir.
Yes, sir.
Thank you. So before I start my lecture, I must quote this famous quote from Alvin Toffler: "The illiterate of 21st century will not be those who cannot read and write, but those who cannot unlearn, learn, and relearn." So so laparoscopic surgery, basically, when it is changing from the open to a minimal invasive counterpart, what is most important is the anatomy of the region. So once a surgeon is not aware of the hiatal anatomy, a surgeon who was performing open hiatal surgery, when he switches over to laparoscopic hiatal surgery, if he is not well oriented with the anatomy, then complications like pneumothorax, esophageal, and gastric perforations are found at much higher incidence than an open procedure, just because due to surgeon's lack of familiarity with the laparoscopic anatomy of the hiatal region, or the consequences of struggle to provide adequate exposure for dissection. So a good surgeon doesn't concentrate on technical ability alone, but also on the appropriateness of what you are doing. That's, in fact, is the basic tenet of a good surgeon. So anatomy of hiatal region has got host of structures in this region, starting from gastrohepatic omentum, caudate lobe of liver, esophageal hiatus, phrenoesophageal membrane, gastroesophageal junction, arteries in the hiatal region, veins in the hiatal region, nerves in the hiatal region, celiac plexus, gastrosplenic, gastrophrenic, and gastropancreatic ligament. So there are host many structures in this region which we have to orientate ourselves before somebody starts doing hiatal surgery laparoscopically. So the gastrohepatic omentum is the cranial portion of the lesser omentum, between the liver and the esophagus and the lesser curvature of stomach. This is called the gastrohepatic omentum, which otherwise also called as the Custer's window, and it contains the left gastric artery and vein and the hepatic branch of the vagus. So left inferior phrenic artery vein also you can encounter with lymphatics and lymph nodes. If you open the Custer's window, that means if you open the gastrohepatic omentum, the first structure that you visualize is the caudate lobe of liver. This is the caudate lobe of liver. Why this is important in hiatal surgery? Because when surgeon goes for a cruropexy, approximating both the cruri, at that point of time, this is one structure which is liable to be injured, the caudate lobe of liver. So surgeon must be very careful at that point of time. So a knowledge regarding hiatal anatomy will not only help you for the fundoplication, it will also help you knowing about the Heller's cardiomyotomy, sleeve gastrectomy, truncal vagotomy, and fundoplication. So all these 4 surgeries you can comfortably do if you have a hiatal anatomy absolutely printed in your mind. So esophageal hiatus is an inverted teardrop shaped structure, and the borders are anterior and lateral. They are muscular fibrous edges of the cruri. The posteriorly, it has the median arcuate ligament. In fact, where it joins both the cruri, that area is the median arcuate ligament. It is just opposite 10th thoracic vertebra, 1 inch left to the midline. It lies basically on the left crus, transmits esophagus, both the vagi, esophageal branches of the left gastric artery and left gastric vein, and lymphatics. So when you start dissecting the esophageal hiatus, that means you open the Custer's window, cut the peritoneum along the medial border of the right crus and the esophagus, that's the cruroesophageal junction. Blunt dissection in the avascular plane, and a rent is made between the left crus and the esophagus, that's the retroesophageal window. and always avoid dissecting cranially to prevent a pleural perforation. That's most important. So esophageal hiatal dissection is the division of the phrenoesophageal membrane. That I'll come later. What is a phrenoesophageal membrane and how it is important for a surgeon to know about it, because that's one important structure that can aid the surgeon in doing this surgery much comfortably and in a much better way. And in the mediastinum, in the front you have the peritoneum, right and left you have the mediastinal pleura, and the center you have esophagus with vessels and nerves. So the dissection starts posteriorly. Posterior vagus is always dealt with. That means you have to, when you are retracting the esophagus, the posterior vagus is retracted along with the esophagus so that the posterior vagal injury is avoided. And the hiatal border is much stronger anteriorly. So this is the phrenoesophageal membrane. So why it is important? Because the most important thing that the surgeon need to do in a laparoscopic hiatal surgery or a fundoplication or a gastroesophageal reflux, anti-reflux surgery is mobilization of the lower part of the esophagus. And mobilization of lower part of esophagus is only possible when the surgeon divides this pleuroperitoneal membrane. This pleuroperitoneal membrane, when you divide, you get into a avascular fibrous plane. Thereby, it aids in mobilizing the lower esophagus so that the gastroesophageal junction or the OG junction comes and stays comfortably intra-abdominally. So it is only evident anteriorly. This is a signing fibrous membrane, which we'll see later on. It's a very distinct, strong white fascia stretched in the paraesophageal hernias, and distal 3 to 5 centimeter of the esophagus can be thoroughly mobilized if the surgeon is dividing the phrenoesophageal membrane. So gastroesophageal junction is a crisscrossing of the longitudinal, oblique, and the transverse fibers. Myotomy is difficult in this area. So while doing a Heller's cardiomyotomy, surgeon need to be very cautious. One should not go much below the gastroesophageal junction. And OG junction become indistinct in peptic strictures and post-traumatic strictures like pneumatic dilatation. Patients who undergo repeated pneumatic dilatation following this peptic stricture or achalasia cardia, they in fact have a very indistinct OG junction that creates a problem for the surgeon. So the most important point to remember, the anterior gastric wall just below the cardia and the esophagus just proximal to the cardia are the thinnest areas and vulnerable sites for a iatrogenic perforation while doing a Heller's cardiomyotomy. I am telling you just because I am dealing the hiatal anatomy in a perspective that the surgeon is expected to know the anatomy while he is going to perform a truncal vagotomy, a fundoplication, Heller's cardiomyotomy, or a sleeve gastrectomy. In all these 4 surgeries, a surgeon needs to know this region and the anatomy very clearly. So we have got 2 vagi. The anterior vagus is the one which is present little on the right half of the esophagus, but on the anterior side. And posterior vagus is the posterior vagus, which comes into view very easily once we go into this cruroesophageal plane, this avascular plane. So anterior and posterior vagi are distinctly identified in 80 to 85% of patients. The anterior is located more on the left than the posterior, but both the nerves are located on the right half of the esophagus, and left is anterior, right is posterior. That's the LARP. So median arcuate ligament passes in front of the aorta at the level of L1, formed by the fusion of arms of the left and right crura. In 50% population, it is well developed. In 16%, it covers the celiac artery and may compress it. Celiac ganglion is just below it and should not be injured during a crural repair. And that is the landmark when an anesthetist goes for the celiac ganglion block in patients of pancreatic surgery not getting relief from pain in tropical chronic pancreatitis. So that is the area which is the celiac ganglion area, which is blocked in this chronic debilitating pain. Celiac plexus 1 to 5 ganglia with a diameter of 0.5 to 4.5 centimeter at the level of the diaphragmatic crura insertion. Cisterna chyli is lie just at the L1, L2 between the right crus and the aorta, the cisterna chyli. and deeper dissection may injure leading to chylous ascites. So while a surgeon dissect the cruroesophageal junction, he should never come nearer this area, I mean nearer to the junction of both the cruri, and never try to intervene in this area, that is the zone for the cisterna chyli. So gastrosplenic ligament connects the spleen with the greater curvature of the stomach, leads to the bare area of the posterior wall of the stomach in front of the left crus. It contains the short gastric vessels. And gastrophrenic ligament between the stomach and the diaphragm, medial 2 to 3 centimeter, contains no vessels, so allows blunt dissection of OG junction. And gastropancreatic ligament is formed by a wide area containing left gastric vessels, separates the portion of the lesser sac located behind the gastrocolic omentum from the portion behind the posterior wall of stomach. It contains the left gastric vessels, celiac branch of the posterior vagus, lymphatics, and small retroperitoneal, diaphragmatic, and pancreatic vessels. So in fact, what is more important in this anatomy, if we just go and recapitulate to the initial, my first slide. So out of this host of structures that you encounter, the first thing is most important, the gastrohepatic omentum, that's the Custer's window. Once you open it up, you encounter the caudate lobe of the liver. Then you go into the esophageal hiatus, that's the junction between the right crus and the esophagus, that's the cruroesophageal junction, that's the entry into the esophageal hiatus. You have the phrenoesophageal membrane, which when you divide, then only the lower esophagus gets thoroughly mobilized. The gastroesophageal junction is extremely important if you are proceeding to do for a Heller's cardiomyotomy. Arteries in this region, you are very well aware, just behind you have the abdominal aorta, and the ascending of the esophageal branch of the left gastric artery accompanies the lower part of the esophagus. You have the veins there, nerves in that region, the celiac ganglion, the celiac plexus, and these three ligaments. So in fact, in a nutshell, I have told you about how the anatomy looks like. And as we proceed further, the anatomy will get much clearer when we go into the surgical part of it. So once we are over into the anatomy part, the hiatal hernias are basically of 4 types. The type 1 is the sliding hernia, type 2 is the paraesophageal hernia, type 3 is combined sliding and paraesophageal, type 4 contains the viscera. So this is a sliding hernia where you have a short esophagus. This is the paraesophageal hernia. The OGG is almost near at the normal position, but the stomach has gone in. Type 3 is a combined sliding and paraesophageal, and type 4 is a visceral herniation. You can have the spleen there, you can have the colon there, you can have the stomach there. So this is the type 4 head. Everything, I mean, most of the important organs you can find in the chest. So how do we prepare a patient for anti-reflux surgery? So anti-reflux surgery is a surgery which many a times before going into the procedure, most important is preparing this patient and the pre-operative workup of this patient. That's probably one of the most important thing to get the best out of your surgical result. So basically, why this is important, the gastroesophageal reflux disorder, which is basically the typical symptom, is the heartburn. In a New England Journal of Medicine, the editorial had given this excellent idea about the heartburn. Heartburn is a serious symptom that merits more attention from patients and physicians. It is the hallmark of gastroesophageal reflux, a disorder that may lead to esophagitis, progressing in some patients to the metaplastic columnar mucosal changes known as Barrett's esophagus, and ultimately to adenocarcinoma. So why I'm stressing this much on this? Because heartburn is a symptom which should not be just casually taken. A patient, not the surgeon, should just not neglect it. It can have telltale features of much more severe complications inside. So all this symptomatology has to be very seriously taken, and most typically these patients present with a heartburn or a substernal burn after meal, early, and at the bedtime in the late presentation, and quite often they have got regurgitation. So heartburn and regurgitation are the cardinal signs, as cardinal symptoms of gastroesophageal reflux disorder. Atypically, they may present with chest pain or dysphagia. That's quite often they are misdiagnosed, myocardial infarcts and angina, so much and so on. They are confused with a cardiac problem, but quite often these are just the symptomatology and presentation of a gastroesophageal reflux disorder. And sometimes they present with the respiratory symptoms with cough, dyspnea. Also, all these things will surely follow one after another. So this was a journal which was published in the Journal of Minimal Access Surgery. This is a Leeds experience. Barrett's esophagus, is there a need for laparoscopic anti-reflux surgery? The conclusion of the authors were, yes, anti-reflux surgery has a pivotal role in the treatment of Barrett's esophagus. So before we come to the treatment proper, we must know that all the patients that come to us with a gastroesophageal reflux disorder, we do not just jump on them to do an anti-reflux surgery. And that is very much clear on this slide. 108 patients have reported or consulted for anti-reflux surgery. Out of them, 4 were achalasia, they were sidelined. 104 patients, 62 cases had GERD symptoms. 42 cases had no GERD symptoms, so they are referred back. So only these 62 patients were taken up for surgery. That means out of 108 patients, only 57% underwent anti-reflux surgery. So by that, I just want to emphasize in your mind that anti-reflux surgery is a procedure which should not be just taken up like cholecystectomy or appendectomy. It has got its own iota of complications, and it has got its own iota of sequelae of post-operative events. So patients have to be very carefully chosen, and they have to be very carefully selected. So pre-operative diagnostic workup basically has got these 4 cardinal things. One is a barium esophagogram, upper GI endoscopy, and esophageal manometry, and off PPI, pH 24-hour pH testing. So these are the 4 important investigations which a surgeon is expected to perform, to do before an anti-reflux surgery. But before that, I must also tell you that if a surgeon thinks that I'll be doing all these 4 tests and then do anti-reflux surgery, probably no surgeon can ever do an anti-reflux surgery in his life, particularly in a resource-constrained country like ours. It is not Western country, so that you have got facilities available everywhere. Even today, we are also not having this esophageal manometry with us at the present moment. But does that mean a patient should not undergo a surgery for anti-reflux procedure? No, you can proceed, because that is the way probably every surgeon has proceeded in his life. Not that every surgeon had the ability or the availability of all the 4 tests at his command. So basically, most of the time when probably we started doing anti-reflux surgery, only these two investigations were very important, the barium esophagogram and the esophagogastroduodenoscopy. But later on, for quite some time, we had the availability of esophageal manometry outside and 24-hour pH study available. So if you have an esophageal lab attached in your hospital, that's probably a boon to you in reviewing these patients who are referred for anti-reflux surgery by all these 4 tests. So if you consider these 4 investigations, barium esophagogram, OGD, esophageal manometry, and 24-hour pH testing, it is required in every patient considered for anti-reflux surgery. It is required. So it means all these 4 tests should ideally be done. But if you do not have manometry or 24-hour pH testing, you can only proceed with these 2 tests and with your clinical impression. But esophageal manometry and 24-hour pH study at the present moment are one of the basic requirement of doing it as a pre-operative workup for a patient who is undergoing anti-reflux procedure. So barium esophagogram, how it helps us? It helps in evaluating the global anatomy of the structural problem. Whereas esophagogastroduodenoscopy, it evaluates the mucosa for Barrett's esophagus and esophagitis. Esophageal manometry rules out achalasia, and you can plan your surgical approach very comfortably. And 24-hour pH testing, it documents the pathologic acid reflux, correlate the reflux events with symptoms, especially in patients with erosive non-erosive gastroesophageal reflux disorder. So this is the 24-hour esophageal pH monitoring, which ideally should be done in all patients suspected of GERD and planned for anti-reflux surgery. And endoscopy probably is one of the basic investigation, and quite often you can have these kind of images in front of you. You can have Barrett's esophagitis, you can have high-grade esophagitis, Los Angeles grade C or D, presence of peptic stricture as Saski's ring. I mean, that is quite possible. You can always get them, and quite often they are just balloon dilated by gastroenterologists, which actually need an anti-reflux surgery. And the most important thing is you exclude any presence of any tumor, and you can assess the lower esophageal sphincter quite well in a esophagogastroduodenoscopy. So what are the indications for surgery in a GERD? When the patient has got respiratory complications, laryngitis, bronchitis, asthma, pneumonia, sinusitis, probably these patients, all of them might be having a GERD, which need to be evaluated. So when you come to the treatment of these patients, you have got two things in your armamentarium. The majority of these patients, they respond to non-surgical treatment just by modifying the lifestyle, just by giving adequate dose of PPI or a motility agent, and just telling them few advices like taking not to go to bed just after the food, keeping the head end of the bed little raised. So these non-surgical treatment, quite often 60 to 70% of patients, they respond to this. But though GERD with complications like ulcers or strictures or Barrett's esophagus or esophagitis, Los Angeles grade C or D, incomplete resolution of symptom or relapse of symptom while on PPI, probably these are the candidates who will get benefit out of an anti-reflux surgery. But at this point, I must also highlight, it is conventionally and it is believed by most of the surgeons who regularly do anti-reflux surgery, paradoxically, patients who respond well to PPI, they respond better to anti-reflux surgery as well. So this is a paradox which is quite often neglected, but this is a fact. So how this anti-reflux surgery has evolved, unless you know the past, you cannot know how you are doing things at the present. And your present performance will always decide your future. So anti-reflux surgery evolution has undergone a series of advancements. And once you understand how the procedure has evolved, then only probably you can very well understand the technicality involved in doing an anti-reflux surgery. It all started in 1930 when surgeons correlated hiatal hernia, that's protrusion of the part of the stomach through the esophageal hiatus into the chest, with the gastroesophageal reflux disorder. So they thought, why not just pull out the stomach, pull down the stomach into the abdomen and approximate both the cruri, that's the cruropexy. But people found that just by doing a cruropexy had absolutely no result, I mean, no positive impact on these patients. So in 21 years after, Philip Allison gave an impression that it's not only the cruropexy which is going to sort out the problem, neither crural separation or widening of the esophageal hiatus is the only crux of the problem in a gastroesophageal reflux disorder. So what you need to do is you have to improve the function of the cardia than to only reduce the hernia. So the people then started thinking it is not only by reducing the contents to the abdomen and just by cruropexy, it is not going to solve the problem. You have to improve the function of the cardia. So then the emphasis was put on the gastroesophageal junction back in the abdomen. So that led to different kinds of changes in surgical concept. So how to bring this gastroesophageal junction back into the abdomen and stay in the intra-abdominal part? Then surgeons started doing a gastropexy. They just pulled the stomach to the anterior abdominal wall with a hitch so that the GE junction remains inside the abdomen. Then some surgeons started anchoring the gastroesophageal junction to the median arcuate ligament. Then gradually, people thought that we are doing all this nonsense. This is not going to benefit in any way. We can give a wrap of the fundus around the lower part of the esophagus and fix this wrap so that the G junction and the main thing, the G junction will be back in the abdomen, as well as it will improve the function of the cardia. Then probably this gastroesophageal reflux disorder will get much more relief. And from there on, started the Nissen's fundoplication and Toupet fundoplication. So how do we perform an anti-reflux procedure? A hiatal hernia is basically a protrusion of the stomach into the mediastinum through the esophageal hiatus of the diaphragm. So you have got three procedures for a fundoplication. You have got Nissen's, you have got Dor, and you have got Toupet. Out of these three, Nissen and Toupet are usually done for the gastroesophageal reflux disorder, whereas the Dor fundoplication is reserved for those patients of achalasia cardia undergoing a Heller's cardiomyotomy, where you have perforated inadvertently the mucosa, so that you suture the mucosa with a 3O PDS or a Vicryl, and over that sutured mucosa, you put the fundus as a patch. That is what is called as a Dor's fundoplication. So Dor's fundoplication is almost reserved for patients of achalasia cardia undergoing Heller's cardiomyotomy, when the surgeon has inadvertently perforated the mucosa. Otherwise, all those patients of Heller's cardiomyotomy, after a cardiomyotomy, they undergo a anti-reflux procedure with a Toupet fundoplication, so that the myotomy component gets stretched, they remain separated, they do not get approximated easily, and patient gets all the relief. I think I am very clear on this. So basically, for gastroesophageal reflux disorder, you have got Nissen's fundoplication, you have got Toupet fundoplication. Dor is mostly reserved for achalasia cardia and Heller's cardiomyotomy and a perforated mucosa during a Heller's cardiomyotomy. So the tug of war is going on between surgeons and physicians on this gastroesophageal reflux disorder. Believe me, a surgeon rarely gets a patient referred from a physician for an anti-reflux surgery. It's basically surgeons generate their patients to undertake anti-reflux surgery, because physicians all the time think that with a pill, they can cure everything. So they start giving these patients, keep them on the pills lifetime. Whereas a surgeon all the time think, when a patient is not responding to PPI, when the patient is developing Barrett's esophagus, when the patient is developing grade C or D esophagitis, this patient is it's a lifetime burden on him. So anti-reflux surgery is the answer for him after evaluating this patient with a OGD, barium esophagogram, and a 24-hour pH study and a esophageal manometry. So this tug of war continues till today, and it will continue forever. So what surgery is why it is recommended? Because this is the most reliable therapy that increases the lower esophageal sphincter pressure and the length of the esophagus. It decreases the frequency of transient ileus relaxation because you are giving a wrap, and it corrects the hiatus hernia. So all these three things are very comfortably achieved with an anti-reflux surgery. You are increasing the lower esophageal sphincter pressure and the length of esophagus. You are decreasing the frequency of transient lower esophageal sphincter relaxation, and you are correcting the hiatus hernia. So these three things are very comfortably achieved in an anti-reflux surgery. So what are the indications for surgery? Patients who are intolerant to PPI, requiring large doses of PPI, non-compliant patient, poor response to PPI, large hiatal hernia, patients with stricture, ulcer, Barrett's esophagus, patients having atypical symptoms. These are the patients who benefit the most from an anti-reflux surgery. So what's the primary goal of anti-reflux surgery? It is to re-establish the anti-reflux barrier, adequate lengthening of the intra-abdominal esophagus. That's probably most important. That's why the peritoneal phrenoesophageal membrane is important. Positioning the lower esophageal sphincter in the abdomen and increasing the lower esophageal pressure, sphincter pressure, by giving a fundal wrap. I mean, there is a difference between a wrap and an envelope. Envelope and a wrap. When a surgeon is giving a wrap, that means it is covering the whole of the esophagus at the lower end. That's the Nissen's fundoplication, and thereby you are just after bringing the G junction down to the intra-abdominal part, mobilizing the lower esophagus, And when you are performing a wrap, you are increasing the lower esophageal sphincter pressure. That's why that acts as a barrier for the reflux. And while you are doing all this, at the same time, you are increasing the angle of hiss as well. So primary goal is to fix the OG junction, approximate the wide hiatus with a cruropexy, and without creating any undue side effect. That's probably the crux of the surgery. While the surgeon is approximating the crura, doing a cruropexy, or while the surgeon is making a wrap around the lower part of the esophagus. So what is more important is the length of the wrap, the tightness of the wrap. If the surgeon is not conscious for these two things, that's going to give much more undue side effects that the surgery, with this, the surgeon either will forget doing this surgery in his lifetime or make the patient's life most miserable. With dysphagia, there can be herniation of the wrap to the chest. So many complications will just crop up. That will be coming to the nuances of anti-reflux surgery. So what are the steps of the Nissen's fundoplication? The first procedure and the first step is a hiatal dissection. Creating a floppy fundal wrap. You have to create a floppy fundus which can go behind the retroesophageal window for the wrap. If you are going for a Nissen's fundoplication, or if you are going for a toupee, it has to be 280-degree coverage of the lower part of the esophagus. Then the cruropexy. Cruropexy is extremely important. You have to approximate the crura. But while doing so, a surgeon needs to be extremely conscious that the cruropexy should never be tight enough. That means, how do I know that my cruropexy is not tight enough? If I am able to pass in or keep my needle holder, which is a 5 millimeter instrument, between the cruropexy and the esophagus very comfortably, that means it is not a tight cruropexy. And nowadays, people have started doing it with this intraarterial catheter, this Seldinger catheter, just inflating 2 cc balloon. If a 2 cc balloon can get accommodated between the cruropexy and the lower part of the esophagus, probably that's definitely not a tight cruropexy. So that's very important. Surgeon need to be very conscious. You should not make a tight cruropexy. Then the wrap fixation. While making the wrap around the lower end of the esophagus, the two things are extremely important. The wrap which is covering the lower end of the esophagus should not migrate axially to the mediastinum, or the wrap should not revert back in the retroesophageal window to its normal position. So to avoid these two complications, what a surgeon need to do? Now he need to take a bite in the lower end of the esophagus so that the wrap remains fixed to the esophagus. It does not have an axial migration to the chest. And to avoid a rotational migration, the wrap need to be fixed to the right crus so that it will avoid a rotational migration. I think I am extremely clear on this. So a surgeon need to be conscious to, while doing a dissection, hiatal dissection, creating a floppy fundus, just do a shoe-sign maneuver. That means in the retroesophageal window, when you take this mobilized fundus to the right side, you can just like a shoe-sign, you can move it either way. And when you leave it, you must see and you must feel that the mobilized fundus is not retracting back to the left side. That means the fundus is well mobilized. It's a floppy fundus. And while doing the cruropexy, it should not be tight enough. You should be comfortably able to place your needle holder, which is a 5 millimeter instrument, between the cruropexy and the esophagus. Or you can keep a Fogarty catheter with a 2 cc balloon comfortably placed between the cruropexy and the esophagus. That ensures that there is no tightness of the cruropexy. And to avoid an axial migration of the wrap needs to be fixed to the esophagus. And to avoid a rotational migration of the wrap needs to be fixed to the right crus. I think this is the essence of steps of Nissen's fundoplication. So let's now watch the video so that everything will be clearer. So this is how a Nissen's fundoplication procedure is started up. When you decide to go for your optical trocar or the first port, it should not be given right on the top of the umbilicus, or should not be given intra-umbilically, or should not be given infra-umbilical. It should be given 1/3 the distance between the xiphoid process and the esophagus. If you make it 3 segments, 1, 2, and 3, this first trocar should be placed between 2/3 and 1/3 junction and little to the right, so that you can avoid the falciform ligament. And once you go inside, then there comes the subxiphoid 5 mm port. This is the subxiphoid 5 mm port, that the right hand working port at the left, the left midclavicular line, and this is the left hand working port on the right midclavicular or right pararectal point at the level of the right hand working port. And this port need to go between the falciform ligament at the membranous part, so that the trocar can very comfortably, your instruments can reach to the hiatus. And just watch to the hand of is Prakash there? Has Prakash reached?
Sir, good morning, sir. I'm sir hearing it, sir.
You are
sir.
hearing. Fine, thank you. I told you now, because residents must know and watch this part of the surgeon's hand movement. What the surgeon is doing here. Initially, when we started a laparoscopic anti-reflux surgery, we are not using Nathanson's retractor. We are using any kind of a blunt instrument or a suction cannula or a blunt dissector passed through the subxiphoid trocar, and we are retracting the left lobe and exposing the hiatal area for the hiatal dissection. Later on, at one point of time, we thought, why not just introduce the 5 mm cannula much deeper inside and just manipulate your left hand, so that you can comfortably also retract the left lobe of the esophagus. Probably Prakash will remember his hand here before he joined AIIMS Bhubaneswar. This is his hand, and how he is manipulating the cannula, you just see. When you are just moving the cannula, Prakash, you must be remembering this. This is nostalgia.
Definitely, sir. Definitely.
Yeah. So this is how the cannula can be retracting the left lobe of liver. Now we are opening the Custer's window. That's the gastrohepatic omentum. And once you have opened it, the first structure that you are visualizing is the caudate lobe of liver. Then you go right up to the right crus. This is the right crus of the diaphragm. This is the cruroesophageal hiatus. The entry point. This is where a surgeon need to dissect and enter into the hiatus. So once the right crus is exposed, this is the pleuroesophageal membrane. This white shiny structure is the pleuroesophageal membrane. Now the dissection goes into the cruroesophageal hiatus. And once you go perfectly into this plane, you enter into absolutely avascular plane. I must tell at this point of time, it's much easier to tell this, that you enter into this avascular plane. But a surgeon, when starts, quite often enter into the right crus itself. And I have burnt my fingers as well doing this. Initially, it becomes very difficult to appreciate this junction and get into this avascular plane. But maybe after 5, 6, 7 cases, surgeon comfortably knows that which plane I need to use. But initially, sometimes I myself have done this mistake, and I have seen surgeons also doing this mistake, getting into the crural fibers, then creating bleeding there and makes the entire field meshy. Then you just get disgusted that this is not my cup of tea. So once you have dissected into the cruroesophageal hiatus, then this is the retroesophageal window which is coming up. And at this point, you can see the left hand is retracting the vagus nerve. You can see the vagus somewhere here coming up here. Yes, you can see the vagus here. This is the posterior vagal trunk. And while the surgeon is retracting the left esophageal and going through the retroesophageal window, retracting the esophagus along with the posterior vagus. And now I'm dividing the pleuroesophageal membrane. So once you divide the pleuroesophageal membrane, that in fact aids in mobilizing the lower part of the esophagus very comfortably, so that the G junction can be placed in the intra-abdominal part quite well. That's the vagus, posterior vagus. So once the right side dissection is done, you can come to the left side, or otherwise you can also start from the left side and come to the right side later. In fact, initially I was a left to right man. I was a right to left man. Later on, I also switched my technique. I started doing from the left side first. U is much easier and much more comfortable. Dissect everything on the left side first. Then the right side becomes much easier. That's also is another way of doing this thing. So now is the left side dissection, getting into the dividing the entry into the lesser sac. So once you divide and enter into the lesser sac, then you have to take care of the short gastric vessels. These are the short gastrics which are getting divided, and probably for all these, the all credit goes to the energy sources and the optics. That makes the surgeon's life much more easier and much more comfortable. So once you divide and make a very floppy fundus, that the whole aim is to make a floppy fundus, well mobilized floppy fundus, which can comfortably go into through the retroesophageal window to the right side, and you can make a very comfortable lap. That's the left cross of the diaphragm, and that's the fundus. Now you can see this is the left cross of diaphragm. That's the junction here, this left cross, so that the entire thing is mobilized from this side. So this can be also attempted initially, so that everything, when it is done from this side, the other side becomes much more easier. So after the retroesophageal window is done, after you have thoroughly mobilized the fundus, you have made a very floppy fundus, then this umbilical tape is passed through the retroesophageal window. You make a knot there. A knot should not be which very tight, just to make a knot for retracting purpose and maneuvering the lower esophageal junction for doing the cruropexy just little later. So you need to be just made a few knots so that you can just grasp the knot and mobilize the G junction. That's the whole aim. So once you have given the umbilical tape, you have now you can see the right cross here. So the whole anatomy can be well seen. That's the right cross of the diaphragm. And what is important in this right cross of the diaphragm is this diaphragmatic fascia. That's most important. Why it is important? Because while you are doing a cruropexy, your needle must include the diaphragmatic fascia. Unless you include the diaphragmatic fascia in your cruropexy, this is surely going to just get cut through. So you cannot make an approximation of these two crura. So while this is the left cross of the diaphragm, there's the right cross of the diaphragm, and this is the diaphragmatic fascia. So while taking a bite, please include this diaphragmatic fascia. And this is where both of them they join. This is the median arcuate ligament area. That's the aorta behind, and the esophagus with the posterior vagus here, and this is the left, like the retroesophageal window. So after everything is done, after you have retracted this umbilical tape, just retracting the OG junction, then the next step of the procedure is to go for a cruropexy. And while doing this cruropexy, this is the most important technical step. While you are passing the needle, your left hand must go beneath the left cross so that you protect the aorta. Of course, initially that is much more required, but once you know that this much depth I required to go, probably that's not very much important. But initially, a surgeon who is starting off doing a cruropexy, he should ideally just keep the left hand instrument below the left cross, protecting the aorta so that your needle can comfortably traverse the left cross of the diaphragm. So once you have gone across the left cross, then you go to the right cross of the diaphragm. And remember, while going through the right cross, this is the diaphragmatic fascia. You can see the diaphragmatic fascia very well. This is the white diaphragmatic fascia, and that must be included. Once you include the diaphragmatic fascia and throw a knot, then the cruropexy remains stable. You do not have a cut-through effect. So now this cruropexy, just approximate. Don't go for a, just do not use all your might and force. And this is what I am doing exactly now. That's what I was telling before, that while after approximating, I am just evaluating my tightness of the cruropexy. That you could see that while approximating and before putting my final knot, I'm ensuring, this is what I was telling, that my right hand needle holder is just snugly fitting between the cruropexy and the esophagus. That means my crural repair is not tight enough to induce any kind of post-surgical sequelae. So that is how you can assess. And this can also, nowadays people have started assessing with a Fogarty catheter, instilling 2 cc of air. And if the Fogarty catheter is placed comfortably in this zone, that probably ensures you do not have done a tight cruropexy. So once you have assessed and being comfortable and you are satisfied that you are not making a tight cruropexy, throw your final knot. If required, you can go for another knot also. If it's a wide hiatus, and if it is much wider, you can always consider putting a mesh as well. That's also can be done. So after a cruropexy is done, the next step of the procedure is mobilizing the fundus. Mobilizing the fundus from the left to the right, behind the esophagus in the retroesophageal window. So once you have brought the mobilized floppy fundus to the right side through the retroesophageal window, then the next step of the procedure is to do a Su-sign maneuver, just to assess that you have mobilized the fundus well enough so that while you go for a 360-degree Nissen's fundoplication, it is not going to give a tighter. This is how a Su-sign maneuver is done. And what is more important, after you leave the left hand, the fundus need to stay here. That is most important. That means it is not retracting. You can see the fundus is comfortably staying there. And this is important. Just while doing a Nissen's fundoplication for the wrap, your bite, after taking the initial bite to the fundus, your second bite must include the esophageal wall. That means when you make the final wrap, this will prevent an axial migration of the wrap to the chest, to the mediastinum. So this is a U stitch. So I had told you that what is more important is the length and tightness of the wrap. So if you have done a fantastic mobilization of the fundus, if you are taking this bite through the esophagus, that means you are preventing a axial migration of the wrap. And you have assessed already, you have not made a tight cruropexy. That means you are going to do a absolutely superb Nissen's fundoplication. So this is how your wrap should not be tight enough. You should not make also a lengthy wrap. It need to only be 2 to 3 centimeter length. It should be a short wrap. It should be a floppy wrap. That's why I was telling, quite often it should be considered as an envelope than a wrap. You should not completely constrict, because that is how you are going to create complications post-op. So once your wrap is done, then this stitch through the esophagus, which is preventing the axial migration, your next important thing that is to be technically considered is to prevent a rotational migration. So preventing a rotational migration of the wrap, because this wrap should not go back, you are fixing the wrap to the cross of the diaphragm. So that is preventing the rotational migration of the wrap. And while doing that, also I'm always taking the right diaphragmatic fascia. That's most important. We should always include in all our bites to the crust to the diaphragmatic fascia. Unless we are including the diaphragmatic fascia, we are surely going to give a complication post-op. So we have taken one stitch to the esophagus while making the wrap. That is preventing the axial migration, and other stitch to the crus of the diaphragm to prevent a rotational migration. That's a completed Nissen's fundoplication. So if a surgeon is doing Nissen's fundoplication, probably toupee fundoplication is much an easier job. So initially people are thinking that toupee fundoplication is not an ideal procedure, but later on probably many literatures have proved that both the procedures are giving almost equal result. It's not bad to do a toupee fundoplication as well. But quite often we perform a toupee fundoplication with all our achalasia cardia, Heller's cardiomyotomy. So you can take one bite on the, this is a 280-degree wrap, the anterior part of the esophagus, you are just leaving it bare. So you are fixing 2 stitches on either side of the esophagus to the fundus. Quite often these sutures should ideally be ethibond. So this is on the right side fixation. Similarly, you can go for the left side fixation to the esophagus. So one more stitch on the left side will complete the partial wrap. And after that, this need to be pulled little further and to be fixed to the crust so that the initial fixation to the esophagus remains absolutely comfortably placed. There is no tension on the initial fixation. That is the whole aim. So the axial, rotational migration can be very easily prevented. And while taking all your bites, you must include the diaphragmatic fascia. So that is how we are preventing a rotational migration of the wrap. So there are surgeons who routinely perform a endoscopy following a nascent spondyloplication just to know that their wrap is not tight enough to induce any kind of dysphagia, but that's quite often probably not. People who are doing it over even esophageal bougie as well, but those are probably not required that much that they are emphasized. So success of surgery depends most importantly on the appropriate patient selection. That's probably the most important criteria. And the second important thing that the surgeon need to emphasize is sufficient esophageal mobilization. Once you have not mobilized the esophagus well, then probably you are going to land up in a soup. So the esophagus, the lower end of the esophagus need to be sufficiently mobilized. The third is the adequate closure of the crura. That we have already discussed how we can know how our cruropexy is adequate, either by passing on your instrument between the cruropexy or esophagus or putting 2 cc of air in a Fogarty catheter, and the balloon should just be snugly fitting in between the cruropexy and the esophagus. Then the most important thing is the adequate mobilization of the fundus. That need to be a very floppy fundus. Then the correct fundal wrap length. It should not be longer wrap length. You should not be enthusiastic giving in more number of stitches between the wrap so that to make it a longer wrap. It should be ideally 2 to 3 centimeters. Short wrap is an ideal wrap. Fixation of the wrap to the esophagus to avoid an axial migration, and fixation of the wrap to the right crust to avoid a rotational migration. This is probably the only thing that is most important for success of any anti-reflux surgery. So it need to be short, it need to be floppy, it to be nascent spondyloplication. So there are quite often nuances following any surgery. So anti-reflux surgery is no exception. There can be nuances involved in this also. If not well done, quite often I have seen surgeons dividing the posterior vagus inadvertently. That happens. And if you are doing it, just don't hide it. Just add a GJ to it. That's it. If you are not doing it, then again it's going to be a problem. So inadequate, inadvertent vagus division, it's not inadequate, it is inadvertent vagus division. Leakage from the GI tract, there can be, I told you, if a little bit reckless in this dissection, sometime where you can mobilizing or dissecting, you might perforate. That might lead to some diaphragmatic abscesses, splenic upper fold devascularization. It quite often happens, but that's not very grave danger. There can be a failed fundoplication repair, and there can be migration of all these wraps. The wraps can migrate to the chest, the wraps can rotate, all these complications can happen. And very unusually, there can be fistulas as well. You can have gastrobronchial fistula, you can have gastroaortic fistula, gastropericardial fistula. Of course, I do not have any experience of seeing these fistulas, but these are all reported in literature. So a surgeon, while doing anti-reflux surgery, if need to follow the essential steps, probably he will have a wonderful surgical outcome. Thank you very much for listening. I think I am within time.
It was really a very nice.
I think let's
nice actually presentation.
Yes, please go ahead.
We'll ask some questions related to
sure. Definitely.
Let residents ask the senior most Bikram is sir, you can also just add to it. Nowadays they are advising to go in for a pH manometry and the manometry. to find out whether there is really reflux or any esophageal
That
motility
Prakash, from
disorder
the initial part,
before
you
proceeding
are,
for a exam.
I had all described it, them all detail. If we are planning an anti-reflux surgery, we have need to do always 4 tests: a barium esophagogram, esophagogastroduodenoscopy, esophageal manometry, and 24-hour pH study. But at the same time, I just told our residents that when we all started, we never started with all these 4 investigations at hand, and then we started. Probably majority of
Yes.
surgeons in India, when started an anti-reflux surgery, they only started with a barium esophagogram and upper GI endoscopy. And probably still at the present time, majority of surgeons are doing only basing on these 2 tests only. But centers where we are having the facility of doing esophageal manometry and 24-hour pH study is absolutely wonderful to do it, because all these 4 tests are need to be always performed before doing an anti-reflux surgery, so that you can differentiate esophageal motility disorder from this gastroesophageal reflux disorder. Or anything else you want to add to this, Prakash?
No, thank you, sir. It is sufficient, sir. One thing is that about the Cisterna-Kylie, actually, you showed a very beautiful schematic diagram. Have you encountered this Cisterna-Kylie ever in the section of this Hiatal area?
To be very frank, I have never encountered. Probably we do not need to encounter this. Like while doing a laparoscopic cholecystectomy, a surgeon should never run to see the cystic duct CBD junction. That's not required at all. Like the same way, while we are doing Hiatal surgery, we should not run and see the Cisterna-Kylie. Probably if we want to see and run after that, we might injure and complicate more than actually doing any benefit to the patient.
Sir, what about the post-operative diet advice in this group of patients, sir?
Yes, most important post-op advice is probably these patients should be advised not to have all these carbonated drinks, because quite often they produce some kind of a gas bloat syndrome. So for quite some time, at least for a year, they should be refrained from carbonated drinks. That's probably most important thing which need to be advised for patients undergoing anti-reflux surgery. I think Prakash had some network issues. Santanu, you can take over till Prakash joins you.
Okay. Okay. So it was an excellent video presentation, sir. I think residents would have loved to see all the points you described in the anatomy part in the video. So I think no resident has put up any questions in chat box. I advise you to put some questions in chat box during each step.
Residents can
So,
also directly ask questions. Absolutely no problem. They're always welcome to ask directly. I don't know. Our residents are very shy in that aspect.
Can I ask, sir?
Sure. Most welcome, Siddhant, please.
Sir, while explaining about indications for surgery, you told atypical symptoms, sir.
Okay.
What are those atypical symptoms, sir?
I mean, one of the most important atypical symptom is a chest pain. And I told that quite often GERD patients have been misdiagnosed as cardiac patients. And
Yes, sir.
quite often they have been diagnosed as with having angina pectoris. So if a patient gets atypical symptom, not just once or twice, should not bother. But if somebody is getting this chest pain quite often, he gets 10 times in a year, makes his life or her life miserable. Every time the cardiologist failed to find a single problem with his heart or her heart, but the patient complains of all this persistent atypical symptom. Probably in those kind of scenario, anti-reflux surgery will help. And I have seen 3 patients like that till in my short span of anti-reflux surgery career. Probably these 3 patients persistently complain of this atypical chest pain. And every time they did echo, angina, I mean this TMT, this angiography, everything came out normal. And when they underwent anti-reflux surgery, they had a wonderful result. So probably this is where anti-reflux surgery can also be of benefit.
Thank you, sir. Sir, and regarding types of hiatus hernia, sir,
Okay.
You told there are 4 types of hiatus hernia. So, like, for all, is the management protocol same, or will
Yes,
does it vary?
that's a fantastic question. Uh, Hiatal hernia, I told you that a type 1 is a hiatal hernia where you have got a short esophagus. When you have a short esophagus, it is not easier to mobilize that esophagus and bring the OG junction right to the intra-abdominal part. Surely no surgeon ever can do it. Then what the surgeon need to do at that point of time? That point of time, what is recommended is a Colles gastroplasty. Colles gastroplasty means you have to make a tubularized stomach along with the esophagus in the lesser curvature by staple dividing the lower near the fundus, so that once you divide down, the esophagus along with the lesser curvature becomes a tubularized part, and that becomes a pseudo esophagogastric junction, neo-esophagogastric junction, which is placed in the intra-abdominal part. But what is the greatest drawback of this procedure? The greatest drawback of Colles gastroplasty is that you have a tubularized stomach which is acting as an esophagus, and the stomach has an inherent capacity to produce acid. So quite often, these patients of Colles gastroplasty, if not well chosen up, if not well taken up before and not decided thoroughly before taking up a Colles gastroplasty, they also get a miserable life in the form of this reflux of acid all the time, because this tubularized stomach is now acting as an esophagus. And that might sometime also has landed up in future Barrett's esophagitis. So the treatment, as you asked, is not uniform for everything, but majority of our patients, we very rarely encounter a type 1 hiatal hernia. So most of the time, we escape with either a Nissen's fundoplication or a Toupet fundoplication. But if we have a type 1 hiatal hernia, short esophagus, probably Colles gastroplasty is the answer for them.
Sir. And sir, like for type 4, they will require mesh plasty and
type 4 hernias, actually, those are the visceral hernias. After you reduce back these hernias, because this is such a wide hiatus that the spleen is into the chest, the colon is in the chest, the entire momentum goes to the chest. So these are wide opening. This you cannot go for a cruropexy, and you should not also attempt to do a cruropexy. This is an ideal case where a patient should be given a patch, a diaphragmatic patch or covering the hiatus. With this, we have this composite mesh. This composite mesh, the visceral surface of the mesh should face towards us. Then it has to be covered to the hiatus and fixed to the both side crura, or might in some cases we just give little extension to the side of the esophagus, keeping the anterior part always free. So that is what is most required. So probably type 1 and type 4, quite often we need to do these two maneuvers. Type 2 and 3, we surely escape with a Nissen's fundoplication or with a Toupet fundoplication.
Okay, sir. And sir, like, is there any role of Los Angeles classification in GERD patients? Like,
I also probably told in that presentation that Los Angeles grade C and grade D with a Barrett's esophagus. These are the patients where anti-reflux surgery is of tremendous benefit.
Okay, sir. Thank you, sir.
Welcome.
Good afternoon, sir. I have a very nice presentation, sir. I have 2 questions.
Yeah,
sir.
please.
Sir, as you mentioned in the fundal wrap, that should be 2 to 3 centimeter width.
Yes.
So what about the esophageal mobilization, sir? How much centimeter should be mobilized?
Actually,
and second, sir.
Yes, please.
The second one is, sir, there are also there is Watson and there is Toupet and there is Tal also. So whether these 120 degree, 180 degree is out of fashion and only Nissen is being done, or are they also indicated for some other problems?
Coming to your first question, how much, as I told that the wrap should be 2 to 3 centimeter, but I did not tell how much is the length of esophagus that you need to mobilize. Yes, Chiranjeevi, the first thing is we need to mobilize the esophagus. Quite often surgeons are also very somehow or other finicky about the length of esophagus that's mobilized. So quite often I have seen surgeons taking a paper scale into the abdomen and measuring a 6 centimeter length. 6 centimeter length, 3 centimeter wrap, 6 centimeter length of esophagus, intra-abdominal esophagus. But believe me, on a practical note, I also probably never believe in measuring this, because quite often once you mobilize the esophagus well, once you divide the pleuroperitoneal membrane, once you have mobilized, you have seen the pleura right in front of you, you have mobilized it very well, you probably need not do it. But from the initial part, when the surgeon is starting up, if he is that conscious regarding the length of mobilization, that should be around 6 centimeter, it should be mobilized, the lower length of esophagus. Coming to your second question. Your second question is regarding, apart from Nissen, any other procedure should be the standard of care or not. Probably worldwide, these are the two fundoplication which are very comfortably performed, Nissen's and Toupet. All other types of fundoplication that are being described, they are probably not practically they are being done. So surgeons usually prefer to do either a Nissen's or a Toupet. Both of them give equal results. Initially, people are thinking that Toupet is not a ideal fundoplication, but later on, many studies have proved that Toupet is no inferior fundoplication as well, because Toupet is a must in a Heller's cardiomyotomy, can also be done here, but Nissen also can also be done. But apart from these two, all other varieties that you might have read in the book, that probably practically not being performed.
Thank you, sir. Thank you very much.
And sir, one more question, sir. Like, is there any role of post-operative barium esophagogram?
Yes. Barium esophagogram post-operatively, you absolutely don't need to do it. But there are people who try to document things, everything in a very systematic way. So people do routinely barium esophagogram as well as an endoscopy. But to be very precise, you don't need to do a barium esophagogram and do a routine endoscopy post-operatively to check it. People do it intraoperatively as well, I told you. While even after mobilizing the fundus and giving a wrap, people check the tightness of the wrap by pushing on an endoscope. I've seen people also doing a wrap over esophageal bougie, but that's probably not required. It's an overkill.
Thank you, sir.
Welcome. Any further questions from residents? Yes, Santanu, please.
Sir, I have one question. What is the incidence of reversal of Barrett's after doing these procedures?
Incidence of reverse Barrett's, do you mean to say?
Yes, sir. Yes, sir.
Yeah. In fact, to be very precise, I do not have in my whatever little procedure that I have performed, I do not have a personal experience, but I have heard people encountering reverse Barrett's esophagitis. But that probably, I think it is a procedure which is not properly or adequately performed. That probably could be one of the reasons why somebody should get it. Otherwise, a person should not get it. But I do not have personal experience on this.
Right, sir. Right. Any resident want to ask any questions?
I think either there are two things. Either residents didn't understand anything of this, or it was so crystal clear that everything has gone into their gray matter. So yes, Mahesh.
Sir, it was a nice presentation. Sir, my doubt is like, sir, why door is preferred if the mucosa is perforated, like
yes.
doors from perforation?
Yes. When we are doing a Heller's cardiomyotomy, when we are doing a myotomy and till the mucosa is popping out, and unfortunately, inadvertently, if we tend to perforate the mucosa, then we take a 4O vicryl or a 3O vicryl and suture it. At that point of time, just to give a support on this mucosa, because this mucosa is just bare now, it's now open. It has no covering, no muscular covering. So just to give a support on this, we mobilize the fundus and bring this fundus back on this patch anteriorly, just to give a support. That's why Doer's fundoplication is quite often the answer if a surgeon is inadvertently perforating the mucosa in a Heller's cardiomyotomy. But on a routine gastroesophageal reflux disorder or a routine Heller's cardiomyotomy, a surgeon probably never performs a Doer's fundoplication.
Okay, sir. Thank you, sir.
And if you think not a Doer, suppose you will think that I will do a Nissen's fundoplication. Why at all? What is the need? Why at all you take behind the behind the retroesophageal window a wrap and cover it? Why not just put a wrap which is easier to do it, and most easily you can cover the anterior, because you just need to give a support to your repair.
Yes,
So why you need not, for covering this repair, either you can go for a Nissen or Doer. You cannot go for a Toupee, because Toupee is not going to cover this repair. So Nissen will be surely an overkill in a perforated mucosa and a Heller's cardiomyotomy, but Doer will be a fantastic approach in a perforated mucosa.
Yes, sir. Thank you, sir.
Okay.
Sir, I think all the queries have been answered. I think no resident is putting up any questions.
Do our faculties have any questions? Yes.
Hello, sir. Sir, I would like to ask.
Yes.
Yes, sir, this is Vikram, sir.
Yes, please. Go ahead.
Sir, I want to know what should be the choice of doing choice of sutures while doing a wrap?
I told you that the first choice of suture should be an ethibond, because we have tried with silk first, then Prolene. Now probably everything is on ethibond, and ethibond looks very comfortable suture for this. And what's your second question?
Okay, so the next question is what may be the indications of a redo surgery, or what might lead to what may be the presentations which may lead us to do a redo surgery, or like that. I just
redo fundoplication itself is now a big subject, because redo fundoplication is quite often required when we have got post fundoplication complications. Like if you have done a fundal wrap not fixed to the esophagus, as I showed you that while taking the wrap you must fix to the esophagus. Your first one stitch at least should go to the esophagus, so that you should prevent an axial migration, and the wrap need to be fixed to the crust so that you prevent a rotational migration. So if a surgeon is not probably doing it, just making a wrap, then there are chances that this wrap might migrate to the chest. So post-operatively, the patient might have vomiting, chest pain. Patient becomes really catastrophic. And those are the scenarios where a surgeon need to go for a redo fundoplication. You have to dismantle this wrap and go for a adequate cruropexy and a redo fundoplication. That will probably solve this complicated scenario.
And sir, when should it be done? In the index admission, or
it has to be done only on the index admission. You cannot send a patient home with a bundle migrated wrap. You cannot do that. But if a patient post-operatively gone home and coming back with a migrating wrap, then probably that's a different issue. But quite often, if a patient some surgeon has not followed up steps properly, and patient post-operatively had violent cough and all for some other reason, then there is a possibility that the wraps might migrate even in spite of doing a fantastic esophageal suture as well as a crural suture. That might also is possible. But if it is happening, it happens quite often in the post-op period, immediate post-op period. It should redo fundoplication should be done in the index admission. But if a patient coming back after suppose 10 days or 15 days with this fundal wrap migration, then surely at that point of time, it's never on the immediate index admission.
Okay, sir. Thank you, sir. Okay.
Prakash, would you like to give some comments? Final comments regarding summing up this session?
It was a wonderful session, and definitely starting from anatomy till diagnosis till the surgical treatment complications, we had extensive discussion regarding the GERD. I don't think so there should be any doubt further in the diagnosis and treatment of GERD, especially for the postgraduate students and for the also for the faculty members also. And today I will suggest that all the postgraduates should at least read the chapter on GERD. Then they will be having still more doubts. Then you can clarify further.
And not only clarify, they should also try to enrich us. I will be happy that
Yes,
if
yes, definitely.
go through and enrich me, these are the points which you left. They should be highlighted.
The final question, Dr. Tushar wants to also put some question. He is
Please.
also sitting over here.
Is Tushar there? Okay.
Yes, sir.
Yes, sir.
Thank you.
I'm spellbound. I'm speechless.
Okay. Thank you.
Sir, just wanted to know
Yes.
about actually, I'll be very frank. I have missed some part of the initial presentation of yours because
Okay.
of the video.
Okay.
I wanted to know what is the minimum workup of a patient of a GERD
Yes.
before we embark upon surgery.
That's what.
Minimum workup.
Yes, I in fact also highlighted that point. I told that all absolute good workup is to have all the 4 tests. You should do a barium esophagogram, esophagogastroduodenoscopy, esophageal manometry, and 24-hour pH. But the most minimum workup on which basis probably surgeons across the country, when many centers are doing anti-reflux procedure, are only on clinical evidence, esophagogastroduodenoscopy, and a barium esophagogram. There's a most.
That's exactly what I was trying to tell, sir. But if we legally see and academically see,
surely
we are doing, probably we are doing less
absolutely. Absolutely.
Because I agree with you. Even today we have one application posted. That also we don't have the manometry and all the studies which we do for the pressure and pH monitoring. So,
but
I understand because there are very many conditions other than the GERD which sort of coexist.
Absolutely.
So sometimes just going ahead to do a GERD surgery, it might be detrimental if you have not done a proper workup. So that
absolutely, I agree with you. And the present era, no patient of anti-reflux surgery should be posted on the table without these 4 investigation, addition of 24-hour pH study and esophageal manometry. If they are available, it is always ideal to do them so that you can rule out so many esophageal motility disorders, and these patients could have been spared of an anti-reflux surgery, because anti-reflux surgery itself has its own iota of complications as well. So we should not unnecessarily delve in to do anti-reflux surgery for those patients which otherwise could have been spared of this procedure. I absolutely agree with you. But the crux of the problem is, if a surgeon want to do all the 4 tests and do it, probably if we would have done and started that way, probably we would have never done anti-reflux surgery till now. So I mean, you will agree with me that
I do agree, sir.
Yeah,
I do agree. In fact, the patient I'm talking
but
about
resident should always be given the clear message: the patient of anti-reflux surgery should always undergo a barium esophagogram, a OGD, esophageal manometry, and a 24-hour pH study. Then only an anti-reflux surgery. This is the message, clear message.
Practically speaking, probably in the future when our AIMS will be doing this manometry and the pH study, probably the patients will be agreeing.
Absolutely. It will also spare the surgeon from a medical legal litigation, as well as it will help you to decide that this is the patient who is going to benefit most out of the procedure.
Definitely.
Because when I remember there was one patient I had done a frontal ligation.
Yes.
That was long before you had come.
Okay.
So I had done and the patient continued coming. Then Prakash did endoscopy. So first of all, we were discussing probably the frontal ligation failed this thing, and then Prakash says, no, it is very nicely there. That entire thing is, that tube is well made. It is so nicely. So I don't know why the patient is having the problem.
Okay.
So that is how it goes. So students need to know that the surgery is probably not the best way forward until we have properly worked the patient up. At times, if you have not done that, the patient continues to have persistent symptoms, then there is a problem. That there is always a chance for a legal hassle. So that's also what the student need to know.
Sir, there's a question in the chat box from Dr. Amarendra Singh.
Yes.
What is the difference in outcome of anterior door and posterior wrap of Nissen or toupee fundoplication? Is there a difference in the outcome?
I think Amarendra, I told very clearly that if we are considering a fundoplication for gastroesophageal reflux disorder, then we have to consider only between a Nissen and a toupee. And if we are considering DOR, it's only during probably a inadvertent mucosal perforation during a Heller's cardiomyotomy.
Sir.
Okay, so regarding difference between anterior and posterior, I mean, so DOR should never be considered in a GERD surgical armamentarium. DOR is exclusively for that, I mean, for inadvertent mucosal perforation. So regarding toupee and Nissen, probably all literature are now of equal, they're giving equal importance to both. So it is, some or other, I feel, surgeons have got a kind of a fixed mindset. There are surgeons who regularly do only Nissen. They tell that my results are fantastic. There are surgeons who do regularly only toupee. But both ways, I feel both of them, they give equally and good results. There's absolutely no denial to the fact that either of the procedure is superior to the other. But this mindset was little something on the different note a decade back. People are thinking toupee was an inferior fundoplication than Nissen. So whichever you are conversant with, whichever once you are mobilized and done a floppy fundus, it hardly makes a difference whether you are doing a Nissen or a toupee. Toupee is much easier. Nissen is still easier, still much more better than a toupee as well. But the only thing is, while doing a toupee, you need to just ensure that you must be able to pass your instrument, your 5 mm instrument between the wrap and the esophagus. That you should always ensure. And probably by doing that, you need not worry for the post-op dysphagia and all those sequelae of complications.
Thank you, sir.
Welcome.
One thing there now, sir, coming up with the accentuation of the angle of His also.
Yes.
I found few people just elevating the fundus and putting a hitching suture to the esophagus, so that the angle of His becomes more acute.
Acute, yes.
So probably logic is there probably regarding that.
There are studies from AIMS also which having equal results with the angle of his accentuation. I think it is a less right procedure because probably it's looking less flamboyant, I can say. But maybe over the period of time, we will relegate only to that. We might even do away with all these fundoplications and all, because the result wise, I have gone through a few studies from AIMS Delhi.
Okay.
I think it is really a good procedure.
Okay. So I mean, endoscopic procedures are surely giving a tough fight to the laparoscopic procedures. Maybe it's for fundoplication, maybe for Heller's cardiomyotomy, maybe even for sleeve gastrectomy as well. So I mean, endoscopic procedures are always in the evolving phase. They are giving a tough fight, but more or less.
No, this is not an endoscopic procedure, sir.
Okay. No, this is not an endoscopic procedure. This is a laparoscopic procedure. I am telling, I mean, if we are discussing about the cardiomyotomy part, probably POEM is also giving a much better result than a Heller's card. I'm considering from that point of view. So endoscopic procedure in those fronts probably giving a tough fight to laparoscopic procedures as well. And this is good to know that this angle of his, yes, that surely is making an impact. But probably it is not popularly done by every surgeon. So unless and until a procedure which is being replicated by every surgeon, probably that procedure is not going to stand for a longer time.
Agreed. There are some network issues probably.
No, I am able to hear you. So
yes, sir. Probably the postgraduates also need to know in the recent advances, they should know all the names of the endoscopic procedure, like the endocinch is one. So they should know the procedure, because in the recent advances paper, it will be asked definitely.
Absolutely. So I think we have. I don't
see any fresh questions in the chat box.
I think our residents are also all done with their questions. they don't have any further questions probably.
Not seeing any fresh questions, sir.
Okay. So you can give the.
Till then, in this coming week, any resident having any fresh questions, they can put in the forum so that we will also learning and also will be answering it.
They are always welcome, and even other faculties also. Even you have got anything better on this or something new to be known on this GERD, please do not hesitate to post it onto the department forum so that every one of us get enriched.
But I must say, sir, it is a very good initiative. We have started from the esophagus and slowly we'll move caudally, so that all will be presenting one by one.
Yes, definitely.
Operative session will be covered in this also.
I think operative session now on probably we in between will also have some theoretical sessions, not all of the time operative sessions, so that so that it will be a mix and match, and our residents will also enjoy listening to our discussions so that they get a feedback what's actually wrong, where we are deficient, so that we all also can upgrade and update ourselves as well.
And next year, probably after the COVID will be settled, I am hoping soon. So we'll be having a real one, and definitely will be followed up by a small snacks.
Yes, surely, definitely.
So if there are no more questions, sir, we can call it a day.
Yeah, sure.
So it was overall, it was a very nice illustrative presentation. So definitely we'll be carrying it forward. As you said, it will be theoretical also operative session. So both combining will be starting from the esophagus we have started.
Mix and match so that residents will be benefit either way, and all of us also will be benefited. So that things are starting from basic procedure till the advanced procedure, so that everything becomes we can always discuss wherever we have lacunae, we can fill it up and we can advance further. So thank you very
much. Thank you all, and have a nice weekend. So we can call it a day.
Sure. Thank you everybody. Have an enjoyable weekend. Thanks all. Thank you all.
Thank you.